Hello, good afternoon. I'm Dr. Smadar Kort. I'm the Director of Non-Invasive Cardiac Imaging and Co-Director of the BAF Center at Stony Brook Heart Institute. I'm happy to be with you on Go Red for Women Day with our distinguished panel of experts, which I'm going to introduce to you now in no particular order, starting with Dr. Michelle Bloom. Michelle, if you can introduce yourself, please.
Hi, everybody. I am Michelle Bloom. I am an advanced heart failure and transplant cardiologist, as well as a cardio-oncologist here at Stony Brook.
Dr. Noel Mann.
Hello, my name is Noel Mann. I'm one of the non-invasive cardiologists here. I'm also the co-director of the Women's Health Program and also the director of cardio-obstetrics, as well as our fellowship director.
Dr. Alison McClarty.
Hi, everybody. I'm Alison McClarty. I'm a cardiothoracic surgeon, and I'm also the director of the Mechanical Circulatory Support Program here at Stony Brook. And I'm delighted to be here this afternoon to share heart healthy information with you all.
Dr. Grace Chang.
Hi, I'm Grace Chung. I'm a general cardiologist at Heart Associates of Long Island, located in Stony Brook, New York, and I'm happy to be here with the rest of the panelists.
And last but not least, Dr. Adlira Tam.
Hi, everybody. I'm Adlira Tam. Just like Michelle Bloom, I'm also an advanced heart failure and transplant cardiologist here at Stony Brook, and I'm very excited to be with you all today.
Thank you all for introducing yourselves. Myths and misconceptions continue to exist around both heart health as well as heart disease in women. Our conversation today will focus on some of these misconceptions so we can provide you with accurate information and tips that you can implement in your daily life in order to improve your heart health. During the discussion, please submit your questions in the comment section below, or you can use the QR code up on the screen, and we will do our best to answer your questions. So the first myth that continues to exist is that heart disease is more of a problem for men than it is for women. Dr. Mann, can you speak to that?
Yes, well, that's definitely one of the myths that, hopefully we'd like to break today. Many people feel heart disease or think of heart disease as a man's problem or an older man's problem. That's absolutely not the case. Heart disease is the leading killer of both men and women, but in women especially, it actually kills more people than all causes of cancer combined. And actually 50% more women actually die of their heart attack than men do. So it's very important to recognize symptoms. If anything does not feel right, then to seek medical attention quickly.
Dr. McClarty, anything that you would like to add to this?
Yeah, I would just like to add that because of this misconception that heart disease was not a woman's problem, in the early days of developing cardiac research, most of the clinical studies including mostly men and not women. And therefore, there was some bias in the results of these studies and therefore some limitation in our understanding of cardiovascular disease in general that lingers even today. But what we have learned from more recent research is that heart disease is real in women. It manifests itself differently. Women are often older when they present with their heart disease. They often present, therefore, with more what we call comorbidities or additional medical problems. And where in their heart their disease occurs can also be different compared to men. And this, therefore, impacts the ways that women can be treated for their heart disease compared to men. And it's critical that we understand the differences so that we can make appropriate recommendations for our female patients.
There are some misconceptions about the way people present when they have a heart attack. When we see someone having a heart attack in the movies, it's typically men. They typically clutches their chest, they fall to the floor, and when they start talking, they describe an elephant sitting on their chest. Women typically do not present in such a dramatic fashion, although they can present with chest pain And in real life, men typically do not present in that way either. Dr. Bloom, can you tell us about typical symptoms that anyone, man or woman, can have that should make them concerned that they may be having a heart attack?
Absolutely. So as you said, I think that everybody in the world looks at a movie and sees a man clutching his chest and he's sweating and he's pale and all of a sudden he's having a heart attack. And I think we as cardiologists know that that's not what really happens when people come into the hospital. Everybody presents differently, but I would say more typical symptoms of a heart attack would be pain in the center of your chest. It can be dull, it can be sharp. Usually it's a pain that doesn't go away with the usual things like, that you would normally do. And it doesn't go away entirely, even if you take medication. The other thing that can be typical is that chest pain can also be associated with shortness of breath. So you may find that your breath is a little bit short. You're having difficulty taking a deep breath. Can also be associated with palpitations or feeling extra heartbeats, sometimes sweating, and sometimes, things like nausea or indigestion.
And sometimes people don't have chest pain, like you mentioned. They can have other symptoms. Dr. Chang, can you tell us about more subtle symptoms that could still represent a heart attack?
This is a really great point because I don't think every patient will present with a heart attack or heart symptoms with the typical chest pain symptoms. They might feel something in their chest they don't describe as pain. It could be a pulling, it could be a tightness. Some people describe a heaviness. Women especially can also present with symptoms in their neck and their jaw and their arms. Another symptom that we see often that's not really considered a typical symptom is symptoms that people might mistake for GI symptoms. Dr. Bloom mentioned indigestion, nausea. You could also have vomiting. I've also had some people present with pain in their upper abdomen that could be mistaken for something like gallstones. So I think it's really important that if you're concerned about any of your symptoms, that you really speak to your physician and discuss your concerns with them and the symptoms that you're having.
Dr. Tam, typically when we talk to our patients, we tell them to be concerned when they have pain that starts with exertion and is relieved by rest. Does a woman need to be concerned if she has a pain that wakes her up at night or happens only when she is resting?
Yes, of course. Oftentimes, women more than men will experience chest pain when they're resting, or like you mentioned, when waking up or during their sleep. This is a serious event to have because it could represent something that we in the medical field call unstable angina or an acute coronary syndrome. This happens when the blockages in the arteries that are supplying your heart are actually reaching a level that's critical. So critical tightness, that means this is a medical emergency. Seek medical attention is always the rule if you're having chest pain or a heart attack. And you really want to do this. And women, we know more likely than men are not seeking care because they don't really understand that they're having a problem because of the misconception of the way they experience their symptoms. If you are having a heart attack or if you are experiencing any pain at rest, you do want to be at a chest pain center. The chest pain centers are designated to provide the most effective and efficient way to manage patients with heart attacks. They're efficient at doing assessment, diagnostic, and treatments and getting patients ready to our coronary cardiac laboratory.
So I would like to actually put a plug for the chest pain center at Stony Brook, which is the only chest pain center on Long Island, which is accredited for both primary PCI, which is the procedure that we do in order to open a blocked artery, as well as resuscitation, which is the process of restoring circulation and blood flow. So if a patient does have a heart attack and we're extremely concerned, we do rush them to the cardiac catheterization laboratory and perform a PCR. We open a blocked artery, but we don't always go that route, and we have less invasive ways to assess for the presence of heart disease. The laboratory at Stony Brook is the only lab in Suffolk County that is accredited for doing all the typical echo-related procedures, which include transthoracic echo, an echo that is done from the outside, transesophageal echo, which is an echo done from the stomach and the food pipe, as well as stress echo. And in fact, for women, we prefer stress echo over other forms of stress test because it does not involve radiation to the chest. When we use our echoes, which are ultrasound of the heart, we realize that there are differences between the way that women's heart and men's heart look, and we have different templates to actually report the findings based on gender. Dr. McClarty, being a cardiac surgeon, you actually get to see hearts in real time, in real life. Can you share with us some of the differences that you appreciate?
Yes, absolutely. So women in general are smaller than men, and so the hearts of women tend to be smaller than their male counterparts, and all the various parts that make up the heart. And so often when we are talking about heart disease and the kind of heart disease that can be lethal, we're talking about blockages in the arteries on the surface of the heart. So in a woman with a small heart, all these arteries tend to be smaller, and so interventions like stents or open heart surgery that we might do to relieve blockages become technically more challenging just based on the size of the vessels. In addition, we mentioned earlier that women often present at an older age with their heart disease. That being the case, the tissues of the heart are often more friable, more easily torn or ripped. So therefore, we have to be very careful handling the heart of a woman. Add to that with additional age and comorbidities, we see things like plaques or calcium developing in the valves of the heart or the aorta or the large blood vessels attached to the heart, which can crack during procedures. We are well aware that we have to be very careful and pay very close attention when dealing with the hearts of women, especially elderly women, because they are friable and vulnerable to complication. And I will just add one other thing, that often the blockages that can cause these problems can cause heart attacks in women. In men, these blockages tend to be in the beginning parts of the artery, rendering them more easily fixable by things like stents and bypass surgery. In women, unfortunately, often the blockages are further down in the arterial tree in smaller vessels, rendering them less amenable to bypass surgery. Therefore, prevention and mitigating risk factors for heart disease so that you don't even ever develop the blockages is much more important, one could argue, for women, because the ways that we can treat the blockages are somewhat limited at this time.
Another myth is that when someone has a heart attack, it means that they have a blocked artery. We know that this is not always the case, and especially women can have no blockages in their larger vessels, the coronaries, the blood vessels that supply blood to the heart muscle, but they can have a disease of the small vessels, and the fancy name for that is microvascular disease. Dr. Mann, can you educate the audience about microvascular disease and what can be done to prevent it?
Yes, definitely. So the arteries that supply the heart are similar to the branches of a tree. You have the big main trunks that branch into bigger trunks or smaller trunks, and then very, very tiny little branches. And it's the same thing with the blood vessels of the heart. So sometimes we will not see any blockages in the very large vessels of the heart that we can put stents in, but other testing indicates to us that there are blockages within the microvasculature, those teeny tiny blood vessels that we cannot see. And in those cases, we can't put stents or do bypass, but it's very, very important to control your risk factors. And one great resource is actually the American Heart Association's website. They have what they call their life's essential 8. And it's really 8 things that you should look out for. One is your diet. Obviously, incorporating more vegetables, more fruit, less processed meats is very important to a heart healthy diet. The Mediterranean diet is actually the only diet that's been shown to lower mortality in cardiovascular disease, so lower your risk of dying and events. Not smoking, very important for women. Women that smoke live on average 14 years less than women that don't smoke. And women's blood vessels, because they're smaller, are really very susceptible to the effects of smoking. Getting more sleep, that's another one of the life's essential eight, probably one that maybe some of us on this panel probably could do a little bit better at. So 7 to 8 hours of sleep. The other thing, there's a couple others, managing your weight, keeping your body mass index less between 18 and 25, controlling your cholesterol. So always having a baseline cholesterol. We decide whether to treat your cholesterol based on a calculator that looks at many of your risk factors. So your age, whether you're on blood pressure medication, what the actual numbers of your cholesterol are. So that's also very important to control. If you have diabetes, managing your blood sugar. If you have high blood pressure, managing your blood pressure. So ideally, a blood pressure less than 120 over 80, preferably less than 130 over 80. And then activity. It's very, very important to be active every day. The recommendations are 150 minutes of moderate intensity exercise per week. And what I like to tell my patients is that exercising is good for you, but not exercising is actually bad for you. So if you're not exercising, leading a sedentary life, actually is a similar risk equivalent to if you're smoking a pack a day in your risk for heart disease. So it's really important, if you don't have the full 30 minutes and you only have 10 minutes to go out for a walk, it's really important to do that every day. And women, especially as you get older, if you don't do physical activity, you will lose muscle tone. And it's very important also to incorporate some weight and resistance training into that exercise routine.
Thank you for that. We actually got a few questions about risk factors. So, Dr. Tam, for blood pressure control, would you have a different threshold if someone has a family history of heart disease?
If you have a family history of heart disease, you're even more at risk of developing heart disease yourself. So it's even more important for a patient which has a hereditary component to have a stricter control of things like blood pressure. But I would want to also add that you want to control your cholesterol, make sure you don't have diabetes, you don't do any of the other things that obviously Noel was mentioning, smoking, alcohol intake. You want to control all of those because you already have this risk factor of having a family history of heart disease. I always advise my patients, irrespective of their family history, to always aim for a blood pressure of 120 or over 80 or less. We want every woman to be healthy, but particularly if you have risk factors, you want to control all of them.
If your cholesterol is high and you have a calcium score which is 0, would you be aggressive with your cholesterol management?
Yeah, this is a very interesting question because there is more to the high cholesterol than just the calcium score. When we decide whether we start someone on a statin therapy, like Dr. Mann was mentioning, we use a calculator, and this calculator takes in effect a lot of other risk factors, age being one of them, female, all these other things that come into play. So you may need a statin therapy irrespective of having a 0 calcium score. Our goal is to make sure that you have a 0 calcium score for the rest of your life. And at some point, if you cannot control that cholesterol level with diet and exercise, then you may need to be on a statin. And all of this becomes dependent on where you fall in that risk calculator. Are you low risk? Are you intermediate or high risk? If you're high risk, we always say you go on a statin therapy. If you are intermediate risk, that's when the calcium score plays an effect, and maybe some conversations about the hesitations around statin would come into play. And if you're low risk, I normally recommend my patients to start with healthy lifestyle modification and start with that attempt first.
Dr. Mann, in addition to all the risk factors that you mentioned, we got a question about genomics and the role that that may play in the development of heart disease. What are your thoughts about that?
Well, we don't have a specific genetic test for heart disease, but definitely if you have a strong family history, it's really important to be very aggressive with controlling your risk factors. Because no matter, there are people that have a very strong family history, but this does not mean that you still can't mitigate some of those effects with a healthy lifestyle. So, but does it mean that you will put your risk to zero? No, but trying to do your best at controlling your blood pressure, controlling your cholesterol, eating healthy, not smoking is a big one. And really maintaining an active lifestyle is very important to kind of combat those genetics. As I tell my patients, you can't pick your family.
Another common misconception is that breast cancer affects more women than heart disease. Dr. Bloom, you have a special interest in people who have cancer. Can you share with us some of the statistics and also tell us about the interplay between cancer and heart disease and what can be done to minimize it?
Thank you. Yes. So here at Stony Brook, actually, we founded something called a Cardio-Oncology program in 2015, and we're really proud to actually say that it became recently noted to be a center of excellence. The reason why I did this was because it's something that I really became passionate about a bunch of years ago, because I wound up, even when I was doing my training, seeing a lot of cancer patients who developed cardiac disease as part of their cancer therapy. And particularly sort of relevant to today, I wound up seeing a lot of women with breast cancer who either had cardiovascular disease before their breast cancer diagnosis, and that maybe limited their options in terms of what they could get for their breast cancer, but also women who had breast cancer and didn't have cardiac disease. And then because of the therapies that they got, the chemotherapy, the radiation, the other therapies, they may have developed either heart failure or another type of weakening of the heart, or they developed coronary artery disease or what have you. And so this really sort of became a focus of my interest over the last few years. So to your point, Dr. Kort, basically, we know that breast cancer and cardiovascular disease are both excessively common in women. It's actually interesting because if you look at the risk factors in women for breast cancer and you look at the risk factors in women for cardiovascular disease, they're basically superimposable. The risk factors are so similar between the two. All the things that my colleagues were talking about, smoking, high blood pressure, obesity, older age, diabetes, all of the things that put us at risk of one thing are going to put us at risk of another thing. And so it's not surprising that there is a coexistence of the two. But we do know, interestingly, even in women who are survivors of breast cancer, a woman is more likely to die of cardiovascular disease than she actually is to die of her breast cancer, either recurrence or complications of her breast cancer, which is pretty disturbing. To answer your other question, I would say there are a lot of things that sort of go into the conversation, particularly with a woman who's getting breast cancer therapy. And I obviously, as we know, in 2023, breast cancer therapy has come so far that there are so many different things that women can be offered in terms of chemotherapy, immune therapy, other cancer therapies, monoclonal antibody therapy, radiation therapy. So there are a whole bunch of different things. But at the end of the day, all of those things that an oncologist can use to offer to a breast cancer patient can potentially have cardiac side effects. So it's really, really important that women are aware of this and talk to their oncologist and be set up with a cardiologist, ideally someone who has an expertise, but really even a general cardiologist, to talk about your risk before you undergo breast cancer therapy. What are the specific risks? Not to be too long-winded, but very, very sort of briefly, certain chemotherapy agents can lead to something called a cardiomyopathy or a weakening of the heart muscle. Dr. Tam and I, as well as Dr. McClarty, are very familiar with seeing those patients. certain cancer therapies can actually lead to high blood pressure or can lead to high cholesterol. In fact, some of the hormonal therapies that breast cancer patients get long-term can actually lead to cholesterol disturbances, and a lot of people aren't aware of that. And then also radiation therapy. So many women with breast cancer will have radiation to either one or both breasts as part of their treatment regimen. The good news is modern breast radiation is much less dangerous because the radiation oncologists are very well aware of these side effects. And so they're doing these things to limit the amount of exposure of the radiation to the heart. But still, that being said, we know that women who have radiation therapy to the breast over a long period of time can potentially be at an increased risk of blockages in the arteries, of something called diastolic dysfunction, which is a problem with the relaxing of the heart, and other types of heart disturbances. So at the end of the day, we have really great advances in breast cancer, and I think that's the good news. The bad news is we really just need to be aware of the cardiac complications that can come along with that. And really, I hope that women can be aware of this so that they can talk to their doctors about it.
Thank you. That was great. Other misconception is that heart disease is a disease of old, less fit people. Dr. Mann, can you share with us some stories about some of the women, specifically the younger women that you get to see at the Women's Health Center, without obviously disclosing any patient's information?
Yes, happy to. So younger women, there's some other risk factors that are unique to women. That if you have this at a younger woman, you should be very aware and kind of on top of your health for the rest of your life. So having preeclampsia when you're pregnant, having hypertension in pregnancy, having PCOS or polycystic ovary syndrome, autoimmune diseases, and those conditions actually put you at increased risk for heart disease as you get older. Additionally, I'm sorry, I lost my train of thought. I'm sorry. Autoimmune diseases as well. Like I said, the jury is a little bit out on hormone replacement therapy. So it's important, again, like we said, to manage these risks and be aware. I'm sorry. Okay. So younger women. I'm sorry. I went on my little tangent. So I do actually have some women that if you looked at them, you would never ever think that this particular person could develop heart disease. And one particular patient that I think of in particular is very thin, very fit, but she did have a very high cholesterol that she wasn't aware of, and ended up having a heart attack. Had very atypical symptoms, so delayed getting to the hospital, and did actually sustain some damage to her heart muscle. She's done remarkably well. We've gotten her cholesterol under control. Her blood pressure is very good. And so she's done very, very well after. But if you were young and if you have a family history, you may be very healthy, very thin, but still have some risk factors that you're unaware of. And, cholesterol, unless you have a blood test, you won't be aware of your cholesterol level. High blood pressure is called the silent killer for a reason, because many patients don't even feel that they have high blood pressure. Some people will, but oftentimes you don't. So, I do also have many patients that are older, but being aware of those very atypical symptoms, many times women will say they just don't feel right. I always tell our trainees about this one specific woman that just had pain in her armpit, and that was her heart attack. So again, being in tune to your body, and if something's unusual, seek medical attention.
That's great. And we always tell our patients that it is important for them to know their family history, because if someone has first-degree relatives with heart disease, that puts them at high risk. a misconception, actually a dangerous misconception, is that to think that if you do have such family history, then you're doomed. You are destined to get heart disease, and there's really nothing that you can do about it. Dr. Chang, how do you clear this misconception to your patients?
I think this is a really important point. I get this question a lot. Like, I mean, if I'm destined to have heart disease, what can I do to really help this? And I really focus with my patients on their lifestyle changes. Look, as one of the other panelists alluded to, you can't change your family, but you could definitely change how you manage your genetics and your family history. So if you have high cholesterol, you have high blood pressure at a young age from your genetics, you have to be aggressive about treating those things. You have to go to your doctor, you have to take your medications, but possibly even more than that, you have to really focus on lifestyle changes, meaning diet, exercise, and sleeping. So one kind of example I give to my patients is that if you take two people and they have the same labs and the same family history, and they both need a heart procedure, the patient who exercises and eats healthy is going to do so much better after any kind of heart procedure or therapy than the patient that does not exercise. So if you want to have the best outcome possible, you have to, be aware of your risk factors, your genetics, your family history, but you really have to focus on your overall lifestyle and maintaining a healthy lifestyle in terms of exercising, sleep, and diet.
So this is another reminder for the audience to place some questions in the comments below, or if you want to use the QR code that is on the screen right now, feel free to do that so we can answer your questions as well. The last point that we're going to discuss is actually not a myth, and it's not controversial at all. As we alluded to before, we all know that incorporating healthy habits into your life improves heart health. So I will ask each one of you to share with us one habit that you are incorporating into your own life that we can all learn from. And I will start with Dr. Mann, who I know used to exercise early in the morning, and I truly admired you for doing so. I could never get up as early as you do to exercise. So are you still doing that?
Yep. Every morning well, except on the weekend, not that early, but yeah, I make it a habit to exercise every single morning. It's sometimes difficult to kind of drag yourself out of bed, but I always remind myself that I always feel better after I do it. I'm also very careful about what I eat, try and maintain a healthy body weight. I obviously don't smoke. So I try and practice what I preach. I think, as physicians, if we don't practice what we preach, then that's a little disingenuous. So that's, I try to eat as many vegetables, try and incorporate more plants into my diet, choose fish, rarely eat red meat. So that's, those are sort of the main things. I think the other thing I really like to emphasize to people as well, when you're exercising, cardiovascular exercise is really important, but also to do some weight training. There was a study that showed that for every week week that a patient is in the hospital, they lose 6% of their muscle tone. So if you're hospitalized for whatever reason, and you have very poor muscle tone to start, by the end of the week, you may not walk out of the hospital. You may end up having to go to a rehab. So it's very important to make sure that you add some weight training so that you can maintain your muscle tone. It helps prevent falls, which are, a big cause of morbidity and mortality in older women.
It also helps with prevention of osteoporosis, or at least maintaining bone density. So absolutely cannot agree with you more. So I do not exercise in the morning, but I do exercise at night. And one of my Peloton buddies is Dr. Bloom. So Dr. Bloom, share with us what you're doing.
Yeah, so I'm not nearly as good as Dr. Mann. I do, if I'm going to exercise, I definitely exercise in the morning before I come to work. I actually make a promise to myself that I'm going to do something on my Peloton app on my phone every day. So either that means I'm riding for 20 or 30 minutes, or that means I'm doing light weights with my arms, or I'm doing core exercises, or I'm doing like a little Pilates. So I really try to do something active for 20 to 30 minutes every day. Usually it's riding, but sometimes it's the other things. I actually have to say too, so many of my patients know that I'm addicted to my Peloton bike that many of my patients, even though a lot of them are heart failure patients and some cardio-oncology patients, they actually follow me and I follow them on Peloton. And it's special for me because I know that, sometimes I'm actually riding with my patients. Sometimes when it's nicer out once a week, I'll play tennis with my friends as well. But I would say for the most part, I really just try to make a conscious commitment to do some type of moderate physical activity every day.
And I think that the pandemic actually helped in a way because there's so many options now to exercise at the comfort of your home. You don't have to go to a gym, and you can pretty much exercise whenever it works for you, whether it's early in the morning or during a lunch break, using your app, or at night like me. So definitely more options, and you should definitely figure out what works for you and incorporate that into your schedule. Dr. McClarty, what are you doing?
So let me say two things. I will tell you what I'm doing in one sec. I just saw that a question popped up in the chat. I want to take 1 second to address it. We've been talking about heart disease and how it can develop, and it can be silent until it causes problems. And what we've been focusing on is coronary artery disease, which is ischemic heart disease, which certainly can be lethal. Another problem of our heart that can be silent until it's problematic is an aortic aneurysm. So there was a question about a medium-sized aortic aneurysm, which is a swelling of the artery, the main artery of the heart. And if it gets really, really big, these arteries can pop or tear and cause a lot of trouble. So just like early coronary artery disease, small aneurysms, you don't feel them until they cause trouble. So if you know that you have an aneurysm or you're told of one, you need to be monitored to see if it is going to grow to a size enough where it's going to now be at risk for complication. So for our audience member who asked the question, if what you have is a mild aneurysm, chances are you're going to be good for the rest of your life. You do need to be monitored, and if it starts to grow at a rate of about half a centimeter a year, or it hits the size of about 5 centimeters, that is when one should start seeking attention for possibly fixing it. So, sorry to digress. In terms of what I do to keep myself healthy, I do a couple of things. I try to exercise. I don't like exercising, so the kind of exercise I do, I try to do things that I enjoy. So, for example, I like tennis, so I play tennis. I play it badly, so that has me running up and down all over the court, so that's good exercise. And I like dancing. I like ballroom dancing, and so I don't do that well either, but again, it keeps me moving, and I think finding activity that you enjoy is key so that you'll do it. Because if you don't like doing something, chances are you won't be able to bring yourself to do it. And the one other thing I do, and I'm more mindful of this now as I'm getting older, is I try to be aware of when I am in a stressful state. And when I am, I can feel my muscles all tensed, and I think that has a physiologic effect in our bodies that can translate into being a risk factor for heart disease. And so I think being mindful of being in a stressful state and taking measures to bring yourself down out of that is also very helpful.
And that's a form of meditation. And there's so many ways to meditate and relax your body. And there's so much data to show that by doing so, you can lower your blood pressure, you can lower your heart rate, you can really improve the function of your blood vessels as well. So very important to recognize when you're under stress and try to relieve that in those fashions. Dr. Chang, share with us what you're doing.
Probably, well, in addition to exercising, probably the biggest thing I've done for my heart health is changing my diet. If anybody knows me, I love sweets and I love eating like a lot of refined sugar. That was kind of the way I used to always eat. But now I realize the harms in, diabetes. We could have a whole talk about diabetes and cardiovascular disease. So the biggest thing I do is I make sure I get vegetables every day, real vegetables. French fries don't count. And I cut back on the refined sugars that I eat. So I won't never eat anything that has sugar, refined sugars in them, but I really try to limit that and make sure that is not my meal for the day. Like I won't have a sugary breakfast cereal or eat something sugary for lunch as my meal. So that's the biggest change I've done.
Dr. Tam, before you tell us about what you're doing, there was a question about inflammation. Can you tell us about inflammation and heart disease?
Yes, we know that at least inflammatory diseases or even autoimmune diseases like Dr. Mann had mentioned earlier, rheumatoid arthritis or lupus or scleroderma, other types of inflammatory diseases have increased risk for heart disease. So, there is some data out there that having elevated levels of inflammation could lead to heart disease by other secondary means, such as elevated blood pressures. You could have diabetes or cholesterol, and all those compounding together could lead a woman to have more increased risk of heart disease. So it's important to recognize that and find ways with your physicians to treat them. And I guess I could go on and talk about what I do.
Yes.
I think I'm the one in the panel here who has a toddler at home. So when I'm not chasing him around the playground or tennis court or the basketball court, I try to at least every day in the evening to do some form of exercises. I haven't purchased a Peloton yet. So for women out there who do not have a Peloton or don't have the means for a Peloton, there's other ways to do this. I actually use, on Netflix, there is a lot of apps that have fitness exercises, regimens from 20 to 30 minutes, which I use those classes with the instructors every night after I put my son to bed. And they go through cores and cardio, and they're really, really fun to do, and they go by very fast. So I do that usually 5 times a week. And then on the weekend, as a family, we like to do a lot of outdoor things with our son and stay active in that way, hiking, playing basketball, like I mentioned. My husband and I sometimes make attempts to play at tennis, and he runs after us, and we're all out of breath by the end. I just also wanted to add, as everyone else mentioned, a little bit pitch about the diet. Having been born and raised part of my life in the Mediterranean, I love the Mediterranean diet, and this is what my family goes by. I think it's really been one of the diets that has proven health benefits so far in studies, and we do that in our family on a regular basis. So we're really strict to a lot of fish, lean protein. We limit to just chicken breast and turkey, as well as a lot of vegetables. We do have fruit, nuts, and legumes a lot in our diet too. And I just feel so much better eating that type of diet at the end of the day.
Thank you. We had a question about bradycardia, which is slow heart rate. So I would say some people have slower heart rate than others, and typically it is a good thing. But you do want to check with your physician. Some medications can cause that, as well as some medical conditions. So just check with your physician to make sure that it is still appropriate for you, and there's nothing that is being missed. Dr. Mann, we had a question about the effects of menopause on heart health. Do you want to comment on that?
Sure. So your risk of heart disease does go up significantly after menopause when your body loses estrogen. Unfortunately, there's not much we can do about it, but that's why oftentimes women present with heart disease later, about 10 years after men. So There were some there are some studies on the use of estrogen. The original large trial that actually just ended up discouraging the use of estrogen replacement therapy. Actually, that study enrolled patients that were older. So the average age in that study was 65. So well after menopause, and therefore then they saw risks of stroke, risks of blood clots, and risk of heart attack in those patients. Slightly higher risk in those patients that took estrogen. There are some newer data that suggests that if people start estrogen replacement earlier, that those risks are mitigated somewhat. There is no role for estrogen replacement therapy purely to prevent heart disease. It's only given for symptoms, people that have severe symptoms of either hot flashes. Some other reasons that it may be given is also for if someone has significant osteoporosis. But there's not a role to just take estrogen replacement to prevent heart disease. That that has not been studied specifically in that role. So menopause, unfortunately, is a factor of life that as we get older, we have to deal with. So again, just managing those extra risk factors is important. And I just wanted to add one thing to the one question about inflammation. All of those things that we talked about with diet, many of those healthy foods are anti-inflammatory. So foods that have a lot of color to them, so berries, vegetables that are, bright in color, have a lot of anti-inflammatory effects. Things that are processed, like fast food, processed meats, those are all actually pro-inflammatory. So if you have in inflammation in your body for other reasons, whether it's an autoimmune disease or even coronary disease, it's important to modify your diet to try and eat those foods that are more anti-inflammatory. And we do have a test called the high sensitivity CRP, which can measure your inflammatory levels. And we do use that sometimes when somebody's in that intermediate risk range of whether to treat their cholesterol.
We had few questions about long COVID, and we know that COVID can affect the heart, and patients can have long-term symptoms that are related to the COVID affecting the heart. So Stony Brook does offer a COVID clinic, and I would recommend people to actually get in touch with the COVID center and be evaluated. We typically perform an echocardiogram, like an ultrasound, to look at the function of the heart muscle. And we look to see whether or not there is fluid collection around the heart, and some other findings that are quite typical of those that have or had COVID before. So, and there are different regimens and medications that can be given to relieve some of the symptoms. So absolutely look and seek medical attention for that. We had a question about the use of magnesium for palpitations. So anyone that has palpitations, I would urge them to see their cardiologist if they have one, or their PCP, and really be monitored to see what the palpitations are coming from. There is some data about magnesium helping with some symptoms, but I would make sure that there's really no underlying heart disease that causes it before reaching out to supplements. We had a question about PAT use. Someone is complaining that she's in an environment in which a lot of people around her smoke, and she's exposed secondhand to that. Dr. Bloom, do you want to educate us a little bit about secondhand PAT use and how that can affect the heart?
Yeah, I mean, that's a tough one, because obviously we know that most people recognize that smoking and toxic chemicals can lead to cardiovascular disease as well as other medical complications. So obviously, very importantly, I think many of us do our very best to avoid any toxicities. It's hard when you're in an environment where somebody else is smoking or somebody else is using toxic substances and you're not in a position to remove yourself. I would say if you are in a position to remove yourself or speak to your superiors about placing, if it's a work exposure, to being put into a different, environment where you can avoid those toxicities, that would probably be the best. But that's a really tough one. I don't know if anyone else has any advice.
So there is less data about secondhand pot use than we do have about cigarettes. We know that secondhand smoking and even third-hand, meaning that it's not really the person next to you that smokes, but smoke that is absorbed already into furniture and into the curtains in the house. That's all bad for you. Less data about pot use, and as more and more states legalize its use and more people smoke, I'm sure we will have the data. But it definitely cannot be a good thing for you. And especially if it bothers you and you're concerned, then like Dr. Bloom said, try to remove yourself from that environment. There was a question about over-exerting yourself while you perform cardio workout. So I would say with every form of exercise, when you first start, if you do have any heart condition or any medical condition, first check with your physician to make sure that what you're about to start is safe for you. And then as you exercise and as you progress, just listen to your body. If you do have any pains, any chest pains, then absolutely stop what you're doing. But if you're short of breath, then talk to your physician about it and maybe get a formal stress test done to really see what happens to you when you exercise and correlate it with the symptoms that you have before you go on to exercise on your own. So always listen to the body. Don't push yourself. Don't go from sedentary lifestyle to attempting to participate in a marathon. Really take things slowly and listen to your body as you do. And we did have some questions about congenital heart disease. Dr. Mann, since you get to see some of these patients at the Women Health Center, do you want to just talk very generally about women who were born with heart disease?
So there's many different forms of congenital heart disease, some that are quite lethal early in life, others that sometimes we discover as adult cardiologists. So it really depends on, the type of congenital heart disease that you have. This may mean a hole in your heart, either between the upper chambers or the lower chambers. It may mean dysfunction of some of the valves of the heart or the valves abnormally formed. So again, congenital heart disease is a very large group of patients with a whole spectrum of severity of disease. There isn't a question here also about younger women developing hypertension. So hypertension in younger women, and younger men, you always have to rule out reversible causes of hypertension. So there's a couple that we usually always rule out, and one is called renal artery stenosis, and that's a blockage in the artery going to the kidney. And the reason that you develop hypertension from that is on sort of the other side of the blockage. The kidney sees the blood pressure as low and then produces substances that raise your blood pressure. There are some other causes, such as something called a pheochromocytoma, which is an adrenaline secreting tumor. Usually that's more accompanied by palpitations and some other symptoms. But if you have hypertension at an early age, it's always prudent to rule out these reversible causes, as you can sometimes fix that cause. But oftentimes this happens in patients that have a family history of hypertension in their family. And also weight contributes significantly to high blood pressure. So many patients, I will often tell them that weight loss is actually a good blood pressure pill. So oftentimes losing, excuse me, 10 to 15% of your body weight will, if you're significantly overweight, will really help lower your blood pressure.
Smadar, I just wanted to add to the question about the congenital heart disease. The question was posed by a 51-year-old who was born with a hole in the heart, fixed with a mesh umbrella, and the person says she's doing well, but did the hole in the heart make my heart weaker? And being an advanced heart failure and transplant cardiologist, I quite often see people with weak hearts. What I wanted to say here is that, it's speculating, but it seems like maybe this person had something called a VSD, or maybe something called an ASD. Now, you would know if you had a weaker heart, because to even fix this, you may have received an ultrasound of the heart. And if noted, you would know that that heart has gotten weaker and should be on the appropriate therapies to strengthen your heart back. But if your ultrasound did note that, then hopefully you did not have any long-term damages.
Thank you. We also had a question about chemical stress tests and exercise stress tests, and those are not the same. We typically prefer an exercise stress test because this way we can actually see your physiologic response to exercise, which is what you're going to be doing on the outside. You're going to be stressing yourself by exercising, not by taking a chemical. So it does have more information and very good prognostic information, in addition to looking for evidence of blockages. So if possible, exercise stress test would be preferred. Some patients cannot have it, or there's a reason for us why we want to proceed with that type of a stress test. So always have a conversation with your physician and ask questions why they prefer or why they send you for this test and not another test. Options are available, and having a good conversation with your physician is always advisable. So with that, as we approach the end of the hour, I want to thank you all for joining us on Go Right for Women Day. We hope our conversation helped to clear some of the myths and misconceptions that exist around heart health and heart disease in women. We encourage you to take care of your heart health. It's never too early and it's never too late to adapt some healthy habits and take care of yourself. You can start by talking to your healthcare provider and figure out what is your own risk and see what can be done to reduce that. Most importantly, we want everyone to be familiar with the signs and the symptoms of heart disease and to never ignore them. I want to thank my colleagues from Stony Brook Medicine. Whether you are looking to prevent heart disease or you have an existing heart disease and you want help, we're here for you. We are ready to help. So the phone number is at the bottom of the screen. Feel free to call that 44 Heart number and make an appointment. And I want to wish everyone a happy Heart Month.